Thank you very much. So I'm going to talk a little bit of not just the long-term results, the early and possibly late outcomes of TCAR. So talking a little bit of the evolution, this is kind of important because to understand how some devices or some procedures kind of become the gold standard. So typically we start with a case report. So first successful endarterectomy was done by Michael DeBakey in 1953. And then it usually follows with a case series, a much larger case series, and once we come to a point where we feel, well, maybe this should be compared to the gold standard, we do randomized controlled trials. And we spoke about that a little bit yesterday. Once we have a randomized controlled trial, that is considered level 1 data. People always criticize it, but that is the best data that we have. And for endarterectomies, it was NACET and ACAS that made endarterectomies popular, or compared to best medical treatment at that time, it ended up doing much better. And as everything in vascular surgery, we tried to do less invasive procedures, so we moved on to transfemoral carotid stenting. The first large study, I believe, was Sapphire, using the angioguard from Cordis. Results looked pretty good. It was followed by a number of industry-sponsored studies, and finally, we decided at some point, well, there's clinical equipoise between endarterectomies and transfemoral carotid stenting, so CREST was designed as a prospective randomized study. This, unfortunate for carotid stenting, showed that transfemoral carotid stenting had a much higher stroke rate, and it kind of fell a little bit out of disfavor. We restricted transfemoral carotid stenting to high-risk symptomatic patients in clinical trials. There was still a push for a less invasive technique because there are some patients that were not ideal endarterectomy candidates. So TCAR came about, which kind of followed the principles of endarterectomy. You don't manipulate the lesion, you don't touch the lesion till you get full control. And the data was good enough that FDA finally approved it for standard risk patients. And shown here, endarterectomy is an extracavitary procedure, but it is an invasive procedure. You can see all the important nerves right next to the carotid. So TCAR was kind of introduced as a less invasive option. In fact, the slide on the right looks very invasive. Our instruments are actually much smaller these days. And the principle of TCAR, as shown here, is we get control, and you can see on the angiogram there is flow reversal. I still haven't, at this point, touched the lesion or manipulated the lesion, so we follow all the surgical principles. And once we have flow reversal, we cross the lesion, we balloon and stent it, and this was a symptomatic patient. And symptomatic patients, sometimes you get a lot of debris in the filter that's outside the body, and I'd let usually the flow reversal run for 2 to 5 minutes following the stenting to clean out any debris. And you can see the early results. This was presented in VAM in 2021. If you look at the death, stroke, and MI rate for endarterectomies was 2.6%. For TCARs was 2.9%. That did not reach statistical significance. So both were, so TCARs were non-inferior to endarterectomy in this study. And breaking down the data a little bit more, you can see the stroke rate was 1.1% in 30 days, 1.4% for TCARs. The only place where endarterectomies did a little worse than TCARs were cranial nerve injuries. However, majority of these disappeared within 6 months, and none of them were of critical importance. Then my talk is supposed to be long-term outcomes, and currently we have 1-year outcomes, and you can see endarterectomies, ipsilateral stroke risk was 1.1%, for TCARs was 1.4%. Again, did not reach statistical significance, showing that TCARs are very durable compared to endarterectomy in both the early and the late outcomes. Looking at a few other important factors, I think procedural time is much less, is almost half that of endarterectomies in this study, so it's certainly a cost-saving procedure because OR time is very expensive. And now there's always a talk about how about silent infarcts, which is a big issue with cerebral stenting. And so this study looked at diffusion-weighted MRIs, and these silent infarcts are important because people do believe they are responsible for long-term risk of dementia. So if you look at CEAs, you look at silent infarcts. So these are not symptomatic lesions, but following an endarterectomy, about 17% of the patients will have some small infarcts in the brain. If you look at transfemoral carotid stenting, it ranges from 50% to close to 90%. So it's, in my opinion, almost a dangerous procedure to do if you're worried about risk of long-term dementia. TCAR, on the other hand, is very comparable to endarterectomies, 18%. So it certainly at least stands the test of the immediate risk of microemboli to the brain. Looking at, now this is not TCAR data, but this is a carotid stent data. So they have 10-year data now from CREST looking at durability of stent compared to endarterectomy. So this is not exactly looking at restenosis, but the need for repeat revascularizations, which is actually important because most restenosis does not necessarily need to be addressed. And if you look at 10 years, the incidence of repeat revascularization following endarterectomy was 4.7%, while stent patient was 2.9%. So certainly a very durable procedure. When I started first doing stents in 2000, I always felt like they may not be as durable as open surgical procedures, but at least in carotids, it's a low resistance bed. The brain is very low resistance. It's a short lesion, high flow rate, so it appears to be a very durable procedure. So in summary, if you compare endarterectomies to TCAR, stroke rate, both the early and late, are very comparable. Other major, if you combine stroke, death, and MI, again, data shows they're very comparable, both for early and late. Endarterectomies have a slightly higher incidence of cranial nerve injuries. Both are very durable procedures. If you look at asymptomatic infarcts, again, very comparable. Procedural time, TCAR wins every single time. Certainly patient satisfaction is a much smaller score, lower down the neck in the non-mobile areas, so patients are much more satisfied. Now, there are certain contraindications for TCAR. You don't put all patients in the TCAR basket. If you have very calcified common carotid artery, if the distance from the clavicle to the bifurcation is less than 5 centimeters, you have a small common carotid artery. Circumferential internal carotid calcification is a relative contraindication. However, with the use of shockwave, we seem to be able to solve that problem to some extent, but not all patients fit TCAR. So there are some patients who are better served with an endarterectomy. Now, this is the most important slide. Every time I look at that, I always feel everyone would understand this. So if you look at centers and physicians who offer both TCAR and endarterectomy, their risk reduction for major adverse events are 10%. That's very important to understand. I think if you box all your patients into just one treatment modality, that every time you see a patient, well, I'm only going to do an endarterectomy, your complication rates are going to be higher. If I'm only going to do a TCAR, your complication rates are going to be higher. So if you're able to offer both, you choose what is best for the patient. And in that case, your outcomes are much better. And I do about 50-50 right now. So certainly, at least in my belief, I think if you look at my toolboxes for treating carotid stenosis, I think TCAR is certainly one of the valuable tools and has stood the test of time. Thank you very much.